Hello, I'm Maroua, and today I'm going to talk about a case of a pregnant woman concerned by a serious health condition potentially dangerous for her and her baby, who gladly gave birth to her second child without complications. A 36-year-old woman consulted at 9 weeks of pregnancy because she had headaches. She was normotensive and had no other symptoms. During her previous in vitro fertilization pregnancy, the patient suffered from preeclampsia at 27 weeks of gestation. The programmed fetus was delivered by a cesarean section at 36 weeks. Preeclampsia is a condition where hypertension and the presence of protein in the urine increase the risk of poor outcomes for both the mother and her baby. The medical history of the patient includes a significant narrowing of the aorta situated under the kidneys level, which increases the risk of high blood pressure. This narrowing of this infrarenal artery in this patient may be due to a birth defect called congenital abdominal aortic coarctation or narrowing, or to an aortic tuberculosis, which is an infectious condition. It may also be due to inactive cacaceous arteritis, which leads to an inflammatory state of the arteries, or to a fibromuscular dysplasia that causes abnormal growth within the walls of an artery. Abdominal aortic coarctation or narrowing presents a significant risk of high blood and aortic dissection where blood flows into the layers of the aortic walls. In this patient, the first pregnancy was complicated by preeclampsia and poor fetal growth, but the second one was uncomplicated. A case report in literature described a similar case of a narrowed renal artery complicated by hypertension. A bypass between the aorta and the renal artery was required to normalize blood pressure in that case, but the woman's second pregnancy with her receiving aspirin was complicated by hypertension and premature delivery. There are no other reports of abdominal aortic coarctation in pregnancy. Therefore, optimal management remains unclear. The higher risk of aortic dissection and rupture in such conditions during pregnancy points out the importance of preconception management. Indeed, it is critical to ensure pregnancy planning by a full cardiac examination, including EKG, echo, and genetic consultation. Evidence for surgical intervention before pregnancy for aortic narrowing remaining limited, a multidisciplinary health team is necessary to provide well-guided diagnosis and surveillance and management. On the other hand, there is a lack of evidence for the use of aspirin or calcium in aortic coarctation during pregnancy. In a retrospective study, authors found no significant evidence of a difference between a group receiving aspirin prophylaxis and a comparison group. However, this study was not adequately powered. To sum up, aortic coarctation in our patient was detected due to persistent high blood pressure, demonstrating the necessity to evaluate causes of chronic hypertension in young patients. Further investigations are required to identify a potential benefit in surgical interventions or in aspirin and calcium as a prevention of preeclampsia. In any case, pregnant women with aortic abnormalities should receive a multidisciplinary management in a specialized obstetric center.